Hey everyone, so I hope you guys are staying safe and sound at home. You enjoyed a little bit of a break, but now it's time to get back to work. So I'm going to try this thing with using the video in the down part of the PowerPoint and record this for you, this lecture for you. Usually it takes me about a class period and a half to cover all of this material. So it is likely that I'll probably break this up into two presentations so that you're not sitting for longer than an hour at a time. So I encourage you to watch this just like you would class times. Take time to sit down, listen, take notes. And we're starting with diabetes. This unit will have both diabetes and renal, and hopefully we'll get some of the same, except for, and I'll try to keep in a little bit of my normal jokes. And keep in mind that there will not be a transcript because this is a one-time presentation. So this is supposed to mimic just like you coming to class, much rather than just listening to a recorded lecture. So I will try to repeat things multiple times to be ensured that you are getting it. And of course, we'll have our live sessions where you can come to me with questions. So here we go. So let's start with our objectives. Of course, usually these objectives are similar to what is posted in the weekly course guide. But ultimately, in this unit, we're wanting you to get what are the priority nursing interventions? What are the concepts related to caring for somebody with endocrine disorders, but in particular with diabetic clients or diabetes? I want you to be able to decide about outcomes and trend their risk and identify health promotion activities for the client, and also be able to integrate the care of somebody with an endocrine disorder, in particular diabetics, into your med-surg practice. So I am sure that many of you have treated many a client who maybe didn't come into the hospital for a diabetic type emergency, but they're there for, let's say they got pneumonia or they had a knee replacement, but they also have diabetes. So how do you incorporate that into their care? Of course, our topics for this unit are, we're going to talk about type 1 and type 2 diabetes, and then we're going to talk about some of the conditions that are that can happen with a client, like diabetic retinopathy, nephropathy, and neuropathy. Those all happen as a result of diabetes long-standing or not well-treated diabetes. And then we have two conditions, DKA and HHS, or hyperglycemic hyperosmolar state, that are conditions of extremely high glucose, so hyperglycemic conditions that occur for different reasons. And I'll cover a little bit more about those in the coming up slides. So first we'll talk about a little bit of patho related to diabetes. I won't spend a whole lot of time on this because if you need to go back and review your patho, I suggest you go back and do that through your patho notes. Otherwise, we're just kind of covering some of these general facts about diabetes. And most of you know a lot about it because you care for a lot of clients with that in the hospital setting. So just knowing that this is a chronic but progressive metabolic disease that will require some lifelong lifestyle modification, be it that they are pre-diabetic and they have to make some changes dietary and exercise-wise, or if they are diabetic type 1 or type 2, it's going to require lifelong medications and dietary changes. So that's important to note. They have difficulty metabolizing all energy, so whether they're taking in carbohydrates, proteins, or fats. If you keep in mind that everything will eventually break down to a glucose molecule and they have difficulty processing glucose, then you will make sense. It will make sense for you. So it's all surrounding the insulin. And remember, you need insulin. Insulin is the key that unlocks the pathway for glucose to enter the cell to provide each cell energy. So if we don't have insulin, then we have a lot of glucose floating around in the body, and none going into cells. So what happens is, I just said, we got a lot of glucose floating around in the body. They're going to have high blood sugar or hyperglycemia. And so we just need to be paying attention to that and keeping that in mind. That'll help us focus on some of the things that we'll do for them as their nurse. So a little more in depth about the physiology. Remember, we'll probably spend the most time referring back to beta cells because those are the ones that secrete insulin. However, there are alpha cells and delta cells within the pancreas, and there is an example here on the picture that's posted in the lecture. So beta cells are the ones that secrete the insulin, and so while alpha cells secrete glucagon, beta cells secrete that one key that we need in order to provide our cellular energy through glucose. So if the beta cells are not functioning, and that happens in type 1 diabetics, they have non-functioning beta cells, or if they're poorly functioning, which would happen in type 2 diabetics, their beta cells will be poorly functioning, then that results in the condition of diabetes mellitus. So I already mentioned that there are two types, two main types. Type 1, where they have problems with insulin secretion, being that the beta cells are non-functional, and type 2, where there is problems with the insulin, the action of the insulin, and also sometimes with secretion, depending on the severity of their type 2. But I didn't mention really gestational diabetes before, and you probably talk about some of that in your OB course. So that is diabetes that occurs during the pregnancy, but may resolve following pregnancy. And probably the one thing that you kind of just need to keep in mind for med-surg purposes is that somebody who had a history of gestational diabetes during pregnancy has a higher risk for having diabetes as an adult at another time. So they have a higher risk for being type 2 diabetic if they had gestational diabetes. And in fact, I do have a friend who has a child that's around the same age as my youngest child who had gestational diabetes. Was not diagnosed immediately post-pregnancy with diabetes, but probably after her child turned 1 year of age, she began to display signs of type 2 diabetes, and her labs were showing that. And so now she has a diagnosis of type 2 diabetes, which was originally she had to get controlled with medicine, and now is controlled with diet. So just know that that risk exists. And then something else that you'll talk a lot about now, in particular in the clinical setting, is pre-diabetes. So what we're seeing now are clients who have very close numbers to diabetic numbers. So let's say their A1C, which we'll talk about in just a little bit, is very close, maybe a 5.8, when 6 is diagnostic. And so when you have clients like that, they are considered pre-diabetic, and in that case, they're going to be suggested to enact some of the dietary changes already to try to avoid diabetes. So I kind of have been talking a little bit about some of the risk factors, but let's nail down or drill down a little bit on the risk factors for type 1 versus type 2. So with type 1 diabetes, it is usually a genetic or autoimmune type disorder. You might hear type 1 referred to as juvenile diabetes. And juvenile diabetes, it was referred that way mainly because it typically happened earlier on in life, although it can happen all the way up to the early 20s in an adult. But we started to get away from juvenile diabetes and start describing it as type 1 only, because now we're seeing a lot of juveniles or children who have type 2 diabetes. So starting to change the language there. But in type 1, it can be genetic or autoimmune. The pancreatic beta cells are destroyed, so they're non-functional, and they don't have any insulin production. So you can keep that in mind. No insulin production for type 1 diabetics, which means they have to take insulin. Now, type 2 diabetics, it can be genetic. There is a genetic predisposition. So for instance, my grandmother, maternal grandmother, had diabetes type 2. So, I pay attention to my mother to see if she starts to display. She gets her lab work drawn at least once a year. And then I'm looking also within myself for those signs and symptoms. Luckily, we don't have any, but we are sensitive to that. So genetic can be an issue. Basically what happens is their beta cells become desensitized to stimuli, so they don't really care to release insulin, even though they maybe have the capability. And then also what happens is the insulin that is released from the beta cells in type 2 may be resistant. And so you heard the term insulin resistance, whereas it's not functioning very well to work as a key. So it's almost like damaged insulin. That's kind of a good way to think about it. And then, of course, if you have prediabetes, like I said, or you had gestational diabetes, those also are risk factors. So this is just a brief overview of some of the assessments that you might see. I pretty much talked about a lot of these. Like I was saying, the name changes that we see. Of course, age sometimes does play a role, but of course now you can probably not hold tight to those age, so you don't really have to memorize 30, less than 30, or around 50, because now we are seeing younger kids with type 1 or 2, well, with type 2, when traditionally we've seen them with type 1. And we're also seeing some older children or young adults with type 1 when you might traditionally expect them to have type 2. And then some of the other things that happen, this is pretty common or characteristic. So some of the symptoms, in that it is abrupt onset in type 1, and they have weight loss, so they get sick really suddenly. Whereas with type 2 diabetes, it's a little bit slower onset, and they usually feel tired, they feel weak. They really don't know anything's going on. They just think they're fatigued because of life. So most type 2 diabetics have no clue until they get lab work drawn traditionally, either because they go for something else to the hospital or they're going to see their healthcare provider at their year onset. And obesity does play a factor. Typically type 1 diabetics are not obese, but they can be. But type 2 diabetics usually have an obesity factor there. And we talked about insulin, and of course we're going to do medical nutrition management for both. So what will happen is they'll have darkening of the skin, like on the back of the neck, sometimes in elbow joints. Most commonly we'll see it around the back of the neck. So they have really darkening of the skin, and this can happen in African Americans, it can happen in Caucasians. It doesn't really matter, but it is a definite darkening of the skin that is pretty consistent with diabetes type 2. So oftentimes we will see that occurring, and it will lead providers to test for that, regardless of because it is a pretty common symptom that you might see. So here we have again some of the signs and symptoms, and I just like the little visual, so I kept it here, but I've already talked about all the main ones that you're going to be seeing. So let's transition a little bit to labs. Some of the labs that you might see in relationship to somebody who has diabetes. So hemoglobin A1C is very important. You're going to probably test that in all of your diabetic clients, or you're going to see it listed somewhere in their chart. So in particular, this is a test that measures the average of their blood sugar over 3 months. So for pre-diabetics, we'll see somewhere between 5.7 and 6.4. And for diabetics, we'll see something greater than 6.5. We're even starting to tighten those parameters and starting to give clients a diagnosis of diabetes at 6.0. So not really essential that you remember that. just kind of remember that the preferable hemoglobin A1C is something less than anything less than 5.7. So let me repeat that. The preferable hemoglobin A1C is anything less than 5.7. However, you can be considered pre-diabetic for anything between 5.7 and 6.4, and you are definitely considered diabetic if you have something greater than 6.5. Although there are some parameters. You don't have to memorize that in particular, more so that 5.7 or less is what's desirable. And then you can know that anything greater than that is considered either pre-diabetic or diabetic. Also, a fasting glucose is important. You will see those pretty commonly, like they do them in the hospital, fasting labs. That's usually the kind of labs you'll have done when you go see your provider for your yearly visit. And so we want our fasting glucose to be less than 126. Most providers also are now kind of looking for fasting glucose less than 100, so around 100, but less than 126 is still okay. You might see the oral glucose tolerance test as a diagnostic, but typically we only see that in clients who we are suspecting have diabetes, and also we'll do it in gestational diabetics. So this is commonly seen in OB as the test that they'll have when they're determining if they are gestational diabetics. So in this test, they drink this really sugary drink, and then they check their blood sugar afterwards. It's very similar when they're not even checking for gestational diabetes. Just the concentration of the drink might be a little bit different. So a random serum glucose, you want that to be less than 200. So that is regardless of when they eat. You don't use just one of those random serum glucoses to make a decision about a client status. You got to have multiple random serum glucoses greater than 200 in order to get a diagnosis. And then, of course, CBCs, CMPs, lipid panel, microalbumin, they might have protein in the urine. All of those are looking for some of the complications from diabetes. So if they are starting to display some of the complications, they might have changes in these lab panels as well. All right, so here's our concept slide. So remember you can use your concept book. If you did not take that book home with you, we will start to look at ways we can offer that concept material to you. Because I know that at least for many of our books, they're ebooks as well, but that one in particular is not. So we'll have to start thinking about that, how to offer. But here are the concepts, and most of the concepts we've already covered this semester at some point in time. So you should have some pretty good working knowledge of them, except maybe altered glucose metabolism. We have not spent a lot of time with that. We're going to talk about that in this unit. So here we are with some of our priority interventions. So the interventions are slightly different depending on whether they're pre-diabetic, type 1, or type 2. And so I've listed it here in this chart format. So if they're pre-diabetic, I've already talked about you want to make sure that they're doing some lifestyle modifications. And number 1, they're changing their diet. And number 2, they're working to lose some weight. And number 3, they're adding exercise into their routine, because it is shown that exercise does help to improve the overall glucose level. And so the other thing that is sort of it's actually been pretty well researched, but we're seeing it implemented much more now, is starting metformin therapy if they have an elevated BMI. So in a pre-diabetic who has a pretty significantly elevated BMI, you might start metformin earlier rather than later. And in addition to the lifestyle modifications of trying to lose weight, trying to eat better, and trying to add exercise. And we might also start them on some monitoring of their blood glucose in the morning and evening, depending on some other factors like their BMI and stuff. So a type 1 diabetic who has an A1C that's less than 7. Well, our goal for them will be an A1C less than 7. And let me rewind back just really quickly to explain that the goal A1C for a pre-diabetic is less than 6. So our goal for a type 1 diabetic and a type 2 diabetic is for the A1C to be less than 7. Our interventions for type 1 versus type 2 are slightly different. So both will have lifestyle modifications, both will have medication, but a type 1 diabetic will have to be on insulin therapy for life. And we'll talk a little bit more about how that insulin therapy is prescribed and how they will cope with that a little later. I won't go into that on this slide. And a type 2 diabetic will have medications, but in this case, they start with an oral hypoglycemic agent, and they may need insulin down the road. Some diabetics, type 2 diabetics at diagnosis, require insulin therapy because their A1C is so out of whack. And both will require glucose monitoring. So for nutrition, there are probably, I would say, the main thing we'll recommend is starting a diabetic type diet. And when I studied diabetic type diets, probably the one thing that sticks out to me the most is that a diabetic type diet is probably the type of diet that we all should be eating. It's pretty balanced. It has lower carbohydrates. It has balanced protein and fat. They recommend lower alcohol. Doesn't mean they can't have alcohol, but alcohol readily converts to glucose in the body. So lower alcohol, moderate sodium, increased fiber. And so all of that sounds like to me things that we should be doing normally. The goal for somebody with nutrition is to have glycemic control. And that looks a little bit different for every client. So we want to try to get them in with a nutritionist and let them start to work with them on what changes they can make with their diet. Of course, we can make suggestions as nurses. However, probably it's best to refer them to a nutritionist for changes in diet. For education, I will say there's a lot of responsibility on the primary nurse to provide some education to your client. However, for new diabetics, it's essential that they get hooked up with a diabetes educator who is a nurse specialist. You can actually work as a diabetes educator after you graduate, but you will go through some specialized training and courses in order to serve as a diabetic educator. But otherwise, it's important that you know about some of the self-management issues related to diabetes, maybe understanding how much literacy somebody has, and that will determine how you shape their education. So if somebody has maybe a 4th grade education, you're not going to provide them with loads and loads of things to read. You might provide them with pictures and some examples in that manner, some videos or something to that extent. So just kind of thinking about those things, working with clients, not thinking that you can suggest every single thing that a quintessential diabetic should do and expect them to be able to implement it all at once. More so that you give them small suggestions that they can implement in their lifestyle that makes them sustainable. But our priority in this is making sure that they avoid hypoglycemia, that they have a regulated blood sugar, that they keep their follow-up appointments, and that they avoid infection. So we want to tailor our education in that way, and that does change depending on the client. Now, I did talk about how hypertension a little bit earlier, how that is a common risk factor, or commonly is coupled with clients who have diabetes. So if someone has diabetes and they also are noted to have hypertension, it is important that we want to keep them at a goal systolic blood pressure of less than 140. It will be awesome if we can keep them less than 130 for systolic and a diastolic less than 80. So ultimately a blood pressure of less than 130/80 is our goal. Um, some common medications you'll see people with diabetes and hypertension on are ACEs or ARBs, and some of that is because there is some literature that shows that those drugs are more efficient in diabetics and help to moderate blood sugar as well, although we don't fully understand why that is. We need to teach them about monitoring their blood pressure at home and making sure they are aware or know about what it is every time they go to a healthcare provider. And of course, they also need to be monitoring what their electrolytes are. GFR is glomerular filtration rate. We'll talk a little bit more about that in the renal part of the lectures. But they need to be paying attention to that, because if they have hypertension and they are not regulating and not monitoring it, they can very easily develop kidney disease as a complication of diabetes. And so that's where they might have alterations in their BUN or creatinine. So dyslipidemia can also be a problem that we've talked about. So lifestyle modification, as far as in particular adding increased exercise, because increased exercise can help improve the HDL in clients. So remember, that's our good cholesterol. I don't want to call it bad, but the cholesterol that's less desirable is LDL. And our triglycerides are very moderated by what we eat. So we want to make sure that our clients are exercising, because that'll help improve their HDL or their protective cholesterol. We want to make sure they're paying attention to what they're eating, so decreasing their saturated fat. And they might need a statin. Now, I'm not a fan of statins as a provider because it causes so many other medical problems in people. I feel like control can often be obtained through dietary changes. However, there are a small select group of clients that that's not helpful, and we still need statins. So statins might be prescribed. And those with cardiovascular disease risk, they might be on aspirin or antiplatelet therapy to protect them from a cardiac event. So these people need to follow up with their primary care or a cardiologist, depending on their risk, if they also have elevated cholesterol levels. So for cardiovascular disease, we're just going to move a little bit further into that. People with diabetes have a higher risk, and so we want to be cognizant of what medications they're on. Are they on any blood pressure medications? Are they on statin therapy, or are they on aspirin therapy? If they had an MI prior to that, you want to look at maybe beta blocker therapy. It's not essential that you know exactly what medication they're on, because you're not providers at this point, but these are some ideas behind what you might see in somebody who had diabetes, okay? And then they need to be having an EKG every year. So this is some of the preventative education and looking at their chart and chart audits. Have they quit smoking, or are they still smoking? And also, have they had an EKG and an evaluation by the provider once a year? So the picture on this slide shows about how inflammation coupled with type 2 diabetes can put them at a higher risk for a cardiovascular event. So ultimately, what the train or the arrows are showing is that those who are elevated weight or higher weight have higher inflammation, because we know that fat in the body is inflammatory. Now, that doesn't mean you don't need to have any fat, but excess fat causes higher inflammation in the body. So you have higher inflammation, you have a higher risk for type 2 diabetes. But if you have obesity, inflammation, and diabetes, that puts you at a higher risk for atheroma. So that's an inflammation within the vessel walls, and that can lead to a cardiovascular event. All right, so we're moving on to nephropathy. So when we look at nephropathy, nephropathy, this is a picture in the corner of a nephron in the kidneys. And so nephropathy can lead to, or is basically kidney disease, and they can have chronic kidney disease, which is diagnosed after they have a glomerular filtration rate, remember I said that a few minutes ago, of greater than 60. So in this case, our primary role as a nurse is to make sure they have good glycemic control and their blood pressure is well controlled, and that they are following the primary prevention type recommendations. They're on an ACE or an ARB. They're having their urine checked at least yearly. They're monitoring their blood pressure. And if they do have the glomerular filtration rate greater than 60, they do need to see a nephrologist. So I'll give you an example. My grandmother, who did have type 2 diabetes, she ended up getting chronic kidney disease after she lived with type 2 diabetes for years, probably 30 years, 30 or 40 years, and ended up needing dialysis from it. But it took her much longer to get to this point because she was pretty tightly controlled diabetic. So she was definitely aging, and in her 70s, 80s when she, or 60s, late 60s, early 70s when she was dealing with that part. So that kind of gives you an idea of progression and how much time might pass before they might deal with this. Whereas I have also seen this happen much more sooner in younger clients who are not maintaining good glucose control and good blood pressure control. So retinopathy is another potential complication of diabetes, and that can cause blindness or lead to blindness. So it's essential that as a nurse you recommend that they have a yearly eye exam, and that they are working on glucose control. This picture is a picture of the optic disc, and so clients with elevated blood glucose consistently can have some damage to the vessels in the eye, which will lead to this retinopathy and then can lead to blindness. So neuropathy we see pretty commonly in diabetics. That, as I said earlier, they have problems with pain, numbness, tingling in their feet or hands. Often we see feet first and then maybe hands and other parts of the body. And so this picture is demonstrating monofilament testing that they need to have at least every 6 months, and if they're testing normal, they can move to once a year. This is where foot care is really, really important for diabetics, because if they have the type of neuropathy where they have numbness, the problem will be is that they can have injury to their foot or infection to their foot for a long period of time if they are not checking their feet daily. So some of the instruction we need to give to diabetics is to check their feet daily. And they need to have this monofilament testing with their evaluation, and also try to make sure they have good glucose control. Now, a common medication that you'll see clients taking for monofilament testing, not for monofilament testing, excuse me, for neuropathy is Neurontin. It is or gabapentin. Gabapentin, I should change that. Neurontin is the brand name. Gabapentin is the generic name. Gabapentin is used, also called Neurontin, is used to help with nerve pain. It is also used for depression, so you may have learned about that in that manner. But it's pretty helpful for that. I don't always check, in particular as a nurse, the ankle brachial index, but that's something that you might see on someone's chart who is diabetic, so don't spend a whole lot of time on that. And often diabetics, we do send them to podiatry, and part of that is because of maybe needing to have nails clipped. We don't recommend them to clip their own nails because of the risk for infection if they cut too deep. So they may need to see a podiatrist. Okay, so now we're going to do a little practice question, and I'm just going to kind of talk through it with you. And then this is where we're going to stop for this part of the presentation, and then we'll move. I will post this one, and then I'll record a second part with the rest of the slides. This ends up being about 35 minutes ish, and the other part will probably be around about an hour. So that's kind of normal or typical for how we will do it in class. Although usually I break it up the other way. I go for an hour and then 30 minutes ish. So let's do this question. A client has come to see their healthcare provider for their yearly physical with labs. What alerts the nurse to a potential problem? So we want to select all that apply. So remember, when we are approaching select all that applies, we should approach them with the true false mentality. So will a fasting blood sugar of 90 alert the healthcare provider or alert the nurse that there's a potential problem? Okay, so I hope that you are saying, no, I don't think a fasting blood sugar of 90 will alert for a potential problem. We should be thinking about a fasting blood sugar greater than 126, right? Okay. So what about an A1C of 6.8? Does that alert the nurse that there's a potential problem? I would say yes, because remember, we want to see it less than 5.7, right? And so since they have a 6.8, that's pretty elevated. Now, in the question stem, it does not say that the client is a diabetic, because if it says they are diabetic, it may or may not alert me as a potential problem, because our goal for a type 1 or type 2 diabetic is an A1C less than 7. But this just says a client comes to see the healthcare provider for their yearly physical. So we can't add anything to it. So based on the way it says, I would say yes, B. Okay. Fatigue. Somebody who reports fatigue, does that alert the nurse to a potential problem? I would say yes. And that could be a signal for many different types of problems. Then an LDL of 175, does that alert that there might be a potential problem? I would also say yes, because we want the LDL to be around 100 or less, right? What about a blood pressure of 146/90? I would say yes, because our goal is less than 140/90 or 140/80 for blood pressure. So I would select B, C, D, and E for this question. Okay. All right, so that's going to wrap up the first part of the lecture on endocrine and diabetes, and then we'll come back and talk about some of the medications that you'll see clients with diabetes on, as well as a few more interventions that you might want to keep in mind when you're caring for somebody with diabetes. All right, so I will see you guys soon.